what we've found from that and our ongoing research into wellbeing, that people with poor levels of wellbeing are more likely to be ill. They're more likely to recover from illness slower. They're more likely to be sedentary, exercising less, smoking more, have poorer mobility, poorer self-care, poorer self-management of any conditions, and be using services more. Frequent attendees, have medically unexplained symptoms, or poor attendance rates, not attending when they've got booked appointments. So low well-being is important, not just for reducing prevalence of mental illness, but affecting a whole range of factors within health and social care. From those with high levels of well-being, they're more likely to be in good general health, more likely to be making healthier choices, recovering sooner from illness, managing their illness better, accessing and using services better, have supportive relationships, have assets for health and have healthier living conditions. So better outcomes across education, employment, crime, cohesion, sense of belonging and participation in local communities. So kind of strong evidence there. Deprivation is obviously key. That correlates strongly with levels of well-being, but not as strong as levels of education actually. We found that levels of education were the most strongly correlated to levels of well-being, which is interesting. So huge evidence that we're using to inform our wellbeing inequalities work, and we're still analysing that data, looking at resilience and just doing something around worklessness now. So moving on to the new public health system, we'll have a new public health service in the Department of Health, Directors of Public Health employed by local authorities, jointly appointed with the National Public Health Service, and a ring-fenced budget looking at 4%. We have done some audit of preventative spend across the North West and found the average is 0% with a variation. The health premium to promote action for population-wide health and reducing health inequalities, and an outcomes framework for public health. We have an outcomes framework for health care and one for social care, and a third one for public health will be coming out. And a new cabinet subcommittee on public health chaired by the Secretary of State himself. So by 30th of November, we hope to have the public health white paper. So not long, 2 weeks, is that? There'll also be a health bill in December, and the follow-up to the NHS white paper that's been out for the last couple of months. We'll be looking at special health authorities and the National Commissioning Board being set up April next year, the Public Health Service the following year, and the shadow allocations of the 4% as well there that year, but coming into effect in real terms 2013-14. What we've been doing in the North West is supporting the transition. Dr. Ruth Hussey, the Regional Director of Public Health, is responsible for the transition of the Public Health Service into local authorities. We have a transition oversight group of chief executives from certain local authorities and health trusts, and we have a transition executive group with some of those and directors of public health on that as well. So that is set up around the smooth transition into the new public health service, providing leadership and guidance, ensuring an integrated function, looking at models that reflect different local government structures, different tiers of structure, and we have a set of work streams taking that work forward. I'm conscious of my time now. Just finishing off, we've pulled together 10 asks that we've fed into the development of the white paper, and these are reflecting the work we've been doing with partners on the Living Well framework. So we're asking for a new approach to public health policy, which builds on the assets of individuals, families and communities and strengthens civic society. We want a new approach underpinned by a public health system that creates the right conditions for living well, building on Marmot's 6 recommendations. We want health outcomes that reflect the presence of health and wellbeing in our population and not merely the absence of death and disease. We want health intelligence co-produced with communities, presented in a way that members of the public can easily access, understand and use, but also that it's generated from communities. We're not just relying on statistics coming out of some office somewhere remote from here, but what people are telling us on the ground actually counts as the real outcomes. We want every contact within health and social care to be a health promoting contact. No matter which service we walk into, for whatever condition, whatever need we have, that professional needs to make it a health promoting contact. I can talk more on that, but I'm conscious of time. But I've got 5 minutes. Local authorities, obviously being the place moving forward with this agenda to integrate wellness services across the whole of the public sector. Health protection will be moving into the public health service, but we need to kind of broaden our understanding of health protection, that we're protecting health in a number of forms, from violence, from accidents, from harmful environments. Health and wellbeing boards that will be set up in local authorities. Will they have statutory powers to ensure that all partners are delivering their organisation's contribution to health and wellbeing? That's what we'd like to ask. The Public Health Director, which is known to the local community, which is trusted by the local population and supported by a skilled multidisciplinary team. And lastly, a maintained focus on sustainable development in healthcare, and further developed to exploit the opportunities to deliver the best short-term and long-term health outcomes. That's all I've got to say. Thank you.